All right. Thanks everyone for joining, and thanks Dr. Bishop and Alyssa, and thanks Dr. Tran for being part of this too. Um, so I just want to acknowledge and congratulate Dr. Tran on her graduation and joining us. So thank you. And I have some disclosures there I put up. So what I want to talk about, just kind of briefly review serotonin syndrome. And then I want to go into this phenomenon known as antidepressant discontinuation syndrome. I'll refer to it as ADS. And some with, risk factors. And then the complexities around, dicing out, are we talking about serotonin syndrome? Is it a relapse of their psychiatric illness, or are we talking about something different? And so trying to understand that from the timeline and everything. And so we'll go over that, and then some prevention ideas, some treatment. And then also if we have time, we'll go over some key points that Dr. Tran will go over with our case that we'll present after this. So I'm going to jump in there. I want to just highlight Dr. Wen presented at the ECHO in October 20th. And so I'm not going to go too deeply into what she had already covered already in serotonin syndrome. But I want to say that from my perspective, I have not seen a lot of true cases of serotonin syndrome, because I mostly have read and witnessed it more in patients who have had toxicity and who may be combined with ecstasy or had some other maybe substance use disorder in addition to a serotonergic response. So this is something that I think is pretty rare, but you can go back to Dr. Wen's talk and look at it. But the point is that when I think about serotonin syndrome, I think about serotonin basically side effects on a continuum. There's mild serotonin side effects, and then at the worst, we have serotonin syndrome. And when you look at the neuromuscular abnormalities, when you think about seizure and in that hyperreflexia and clonus, potentially you could get into some muscle breakdown, rhabdomyolysis. You could have rhabdo. Patients could have serious complications, renal complications as a result. The other thing with serotonin syndrome is the confusion. The level of confusion is much more acute. But you can see agitation even with mild serotonin side effects, like starting like an SSRI patient could get agitated, get restless. We sometimes call that akathisia as a side effect, restlessness side effect. Patients can have sweating, mild sweating. They can have nausea, which is very common. But when it gets really severe, patients could start to have like real diaphoresis, where they're really like just become diaphoretic. They're sweating, they have hypertension, they have more autonomic side effects. And that's getting on the other end of the spectrum, the more severe spectrum of serotonin syndrome. Also keeping in mind that sometimes drug interactions can also contribute to serotonin syndrome or those side effects that I mentioned. But the ones that I highlighted are the ones that are going to give us a little bit trouble differentiating between, like, is this serotonin syndrome, or are we talking about a discontinuation syndrome, or that? So I'm going to keep that, like, I just wanted to point those out. So I learned as I did some digging into this that it's this ADS is broken into three main parts. There's acute ADS, and that's new symptoms that occur really early in after stopping the antidepressant. Or there could be rebound, especially in patients who still have like symptoms of their underlying psychiatric disorder, like maybe if they had panic disorder, they might be having panic symptoms. And now after stopping the antidepressant because maybe they ran out or maybe the clinician tapered them quickly. Now they're having withdrawal symptoms that are combined with the underlying illness. And I sometimes say withdrawal, and I it's controversial to say withdrawal with patients because they might think that there might be some substance use connection with antidepressant withdrawal. So I sometimes use those terms interchangeably, but when talking to patients, I try to use this discontinuation syndrome kind of language, so it kind of prevents that stigma from happening, potential stigma. So the third part of this is this persistent ADS, and that's when you start to see that it's not going away. The medication is stopped. There's new symptoms developing, or the symptoms have gotten more severe over time, and it's lingering. It's not going away. It's debilitating. And so these are the three parts. And so what we're going to be looking at today is we're going to be seeing a case that has a combination of rebound and persistent ADS. So, and Dr. Tran will go over that. So just for acute ADS, we see usually early onset. Usually it clears up after a couple weeks. This is a mnemonic that kind of characterizes the symptoms: flu-like, insomnia, nausea, ataxia, hyperarousal. You can see all that with serotonin syndrome, or you could see mild effects even with serotonin side effects. But when you get into like imbalance, insomnia, hyperarousal, patients don't like that, and it could develop into serotonin syndrome. These could be prodromal symptoms to something bigger like serotonin syndrome. Something that's different that kind of puts the thing, puts the spotlight on ADS is the sensory disturbance, like paresthesias, the brain zaps, the electrical feelings, those things that seem more pathognomonic to ADS. So for the protracted, though, usually patients go from an acute ADS to more protracted. What's interesting that some patients who've been on the antidepressant at low doses, maybe for a long time, but at low doses, they develop ADS. And what's interesting about that is maybe they're sensitive. For some reason, that patient might be just sensitive to even low doses, and they might be more likely at more risk for having protracted symptoms even after discontinuation. It can be very disabling. And the onset can be a little bit variable, but usually if it starts out with an acute episode, then it can then you would see it develop early. And in some patients, the durations can be just dramatically variable. And in one paper, I looked at the incident or the percent of patients who had even mild symptoms that seemed to linger were up to just over 50% of patients had lingering symptoms. So that was it's something to keep in mind. And also, these are other symptoms I included just to get at some of the other reported symptoms that happen with this discontinuation syndrome. So if you're a provider and your patient just, the patient stops or you drop their dose, the things that you're going to think about is the patient's underlying psychiatric illness getting worse, or is it something else? And I think that for the most part, when we think about relapse, and we'll talk a little bit about relapse, let's say the patient has depression. If a patient stops their medication, that around 50% may have a relapse of depression after 3 to 6 months. So there is a delay. And the thing is that was well known early on, even with the older antidepressant agents. So we knew that this phenomenon is much more after the SSRIs. So it's a newer phenomena. And so sometimes providers might automatically think that it's a relapse of the underlying symptoms. So we'll go on and explain that a little bit more. First of all, let's talk about risk factors for ADS. And so one of the things is that the duration of treatment is important. Also, higher dose. So the higher the antidepressant dose, the patients on short-acting antidepressants like paroxetine, venlafaxine, they tend to have higher risk for ADS. And then patients who are younger tend to be more sensitive, and we know that with the pediatric population and adolescent population are more sensitive to side effects. So using lower doses is really important. If they have a history of discontinuation syndrome, that's really important to ask about that. And if the patient runs out of their medication, or for some reason there's a discontinuation of the meds, or if it was a planned discontinuation, that could be that seems to be like the #1 risk for ADS, of course. And then looking at those high risk medications as well. Now, there is also a phenomenon known as anticholinergic rebound, which can happen with paroxetine and the tricyclic antidepressants. So you start to see some of the cholinergic symptoms like diarrhea. You can see the sweating. So you can see this kind of overlap with cholinergic rebound from stopping an anticholinergic. So then to complicate things, and then like I mentioned about how do you differentiate then with ADS or relapse. And so it's important to know the timing, of the onset of symptoms. First of all, the timing. For the ADS, it's going to happen early. For relapse, like I mentioned, it's going to happen later. And the duration can range. And that's when you get into that more protracted ADS. If you restart the medication, improvement happens right away. So like the response to reinitiation for withdrawal happens right away, but usually delayed. If you're treating, depression, it's going to take like maybe 2 to 4 to 6 weeks for you to start seeing improvement. Also, what's really important to think about is these combined physical and psychological symptoms combined with ADS. And you don't usually see that, especially the autonomic and neuropathic-like symptoms with like major depression or panic disorder. Patients may complain of some, but not like shock-like feelings or that. Also, this wave pattern, what that means is that as you adjust the dose, if you're trying to lower the dose, patients have this wave of intensity of serotonergic-like symptoms, and then it remits. And then when you go down again on the dose or you make a change, they have another peak of intensity. So you see that more with the withdrawal symptom side than with the relapse. You don't see that usually. When starting an antidepressant, I always warn patients, though, for the first 10 days, you're more likely to see serotonin side effects. But if a patient has that, has a pronounced response to even starting a SSRI or serotonin drug, then I start to think of like the exposure, like could be more serotonergic symptoms, maybe even progressing to serotonin syndrome. So, and then so for prevention, slow tapering, we can talk about that if we have time, how to taper. And then you need to to assess the patient if they have a positive history. If there's worsening depression, anxiety, or insomnia, if it happens soon after the dose reduction, it could be some withdrawal. And so you need to assess that. There is a rating scale that you can use to measure the intensity of these withdrawal symptoms as well. So are the symptoms different before stopping the antidepressant? So that's when we get into those paresthesias or those neurologic symptoms like the brain zaps that we'll talk about. Did the dosage increase cause worsening of symptoms? And that might suggest that it's a side effect of serotonin versus a withdrawal. So if you see an increase after reducing the dose, then we start to think of more of like a withdrawal effect. And so some of the treatment options may be starting to restart the antidepressant. In some cases, I've even had to use every other day dosing to get them tapered off. So, so in summary, what we think, we're not sure exactly what the mechanism of this discontinuation syndrome, but as I like to explain to patients is that when you treat someone for depression, that you downregulate their serotonergic postsynaptic receptors, and by using that serotonergic reuptake inhibitor over time, you downregulate. And now, if you just abruptly stop that treatment, there's this rebound effect or increase of serotonin as our bodies try to seek homeostasis. That this rebound causes those rebound discontinuation serotonergic symptoms in the presence of no, and be either decreased or being off the antidepressant. So before we get into the case, I just want to just point out the Escitalopram metabolism, and these starred ones, 2C19 and 3A4 are the major pathways for escitalopram, and there is CPIC guidelines that you can look up and see that. And then finally is that the interpretation, you can see, and we'll go over the genetic interpretation, just to give you a heads up that we're going to be talking about a poor metabolizer and fairly somewhat rare, 2 to 5%, but Dr. Bishop could jump in there and Dr. Brown could talk more about some of the interpretation as we go. But that's all I had. Is there any questions or any discussion from Dr. Bishop or Dr. Brown?